Clinical scenarios? Certainly. Here's a Puerto Rico Medical Board style clinical vignette focused on cerebellar lesions with various clinical scenarios, differential diagnosis, and explanations. Vignette 1, Hemispheric cerebellar lesion. Patient, a 62-year-old male with a history of hypertension, presenting with instability while walking, difficulty reaching objects with his right hand, and clumsy movements. Physical examination. The patient exhibits dysmetria when performing the finger-to-nose test on the right side, as well as dysdiadochokinesia. Most likely diagnosis, hemispheric cerebellar lesion. Explanation. Hemispheric lesions of the cerebellum are typically associated with ipsilateral ataxia, especially in the limbs. The symptoms of dysmetria, difficulty with fine motor tasks like reaching, and clumsiness are classic signs of a cerebellar hemisphere involvement. Vignette 2, Midline cerebellar lesion. Patient, a 45-year-old woman with a history of chronic alcohol use who presents with difficulty standing without support and a noticeable wide-based gait. Physical examination. The patient demonstrates a wide-based ataxic gait, and nystagmus is noted upon eye examination. Most likely diagnosis, midline cerebellar lesion, likely due to alcohol-related cerebellar degeneration. Explanation. Midline cerebellar lesions, often seen in conditions like chronic alcohol abuse, typically affect the vermis and cause truncal ataxia, presenting as a wide-based gait and difficulty maintaining balance. Nystagmus and difficulty standing without support further suggest involvement of the midline cerebellum. Vignette 3, Cerebellar stroke. A 58-year-old male with hypertension and diabetes who suddenly develops vertigo, nausea, and an inability to walk without assistance. Physical examination, ataxia of the right upper and lower limbs, right-sided dysmetria, and nystagmus. Most likely diagnosis, cerebellar stroke, right side. Explanation, a cerebellar stroke, especially in the posterior inferior cerebellar artery, PICA, territory, can cause sudden onset vertigo, nausea, and ataxia. The right-sided symptoms, including dysmetria, point to a lesion in the right cerebellar hemisphere. Nystagmus is a common finding in cerebellar stroke. Vignette 4, Cerebellar tumor. A 32-year-old female presenting with a 3-week history of progressive headaches, nausea, and difficulty with coordination. Physical examination. She has an unsteady gait and is unable to perform the finger-to-nose test with either hand. Papilledema is observed on fundoscopic exam. Most likely diagnosis, cerebellar tumor, e.g. medulloblastoma, astrocytoma. Explanation, cerebellar tumors, especially in younger adults, can present with headaches due to increased intracranial pressure and signs of cerebellar ataxia. Tumors often affect the midline structures, vermis, and cause truncal ataxia and gait instability. Papilledema suggests raised intracranial pressure, which is consistent with a tumor mass effect. Vignette 5, Chronic cerebellar ataxia. Patient, a 65-year-old male with a history of progressive gait instability and slurred speech over the past 12 months. Physical examination, difficulty with tandem walking, slurred speech, and dysmetria in both arms, no other neurological findings. Most likely diagnosis, chronic cerebellar ataxia, likely due to degenerative cerebellar disease or spinocerebellar ataxia. Explanation, chronic progressive ataxia with a history of gait instability and dysmetria can indicate a degenerative cerebellar disease, such as spinocerebellar ataxia or Friedreich's ataxia. This condition presents with gradual worsening of coordination and speech difficulties.